Hey everybody, Dr. Antonucci here, and I've been getting a lot of requests lately to talk about the updated ACRM definition for traumatic brain injury and concussion. Recently I've been able to attend a couple conferences and meet up with some of the individuals responsible for updating the criteria and the diagnosis for concussion, and they will be publishing these data in June of this year, it seems like. So I wanted to go ahead and just talk for a couple minutes because some of my colleagues were asking me to explain a little bit about the differences in the diagnostic criteria for concussion. So I put together a little presentation. We'll just walk through it real quickly. This will probably take maybe 15 minutes or so just to discuss what it means to be diagnosed with a concussion and the check boxes that need to be checked in order to do so. So as far as redefining concussion, the concussion in sport groups is combining efforts with American College of Rehabilitation Medicine to spearhead the definition and diagnostic criteria for concussion and MTBI. So these data will be published in June of 2023, so not too long from now, just about a month down the road here. We're going to be really getting this new definition of what concussion is and the diagnostic criteria for it. So here's a little preview of what it's going to look like. Now, keep in mind that this is unofficial. It has not been published yet. The Concussion in Sport group is the authority on this, but we wanted to just give a little bit of insight to what to look at, especially because some of my colleagues are in the process of being expert witnesses or doing research, and they're really eager to say, okay, how do I need to define what a concussion is? How do I solidify the diagnostic criteria? Because that sets the foundation for all of their research, that sets the foundation for their diagnosis of their patients. And in any type of litigation, they want to know what they're talking about. So the Concussion in Sport group wrote a preamble to the American College of Rehabilitation Medicine's definition or criteria for concussion. And what they say is that a concussion is a traumatic brain injury caused by a direct blow to the head, neck, or elsewhere on the body. That's super important to realize, is that a concussion can occur if you strike your back or your shoulder or your arms or your legs, or if somebody takes you out from the legs and you fall on your backside, never hit your head, you can still have a concussion if it results in impulsive forces being transmitted to the brain. So what ends up happening in concussion, it initiates a neurotransmitter and metabolic cascade, possible axonal injury, blood flow changes, and inflammation affecting the brain. So that's important to realize, that this will probably be included in the new definition of concussion, that you don't need to hit your head in order to have a concussion. So to say that differently, a concussion is not always a head injury. So head injury and brain injury may not be the same thing, which is important to realize. Another bullet point here, the signs and symptoms may be present immediately or evolve over minutes to hours. So when you have a concussion, you may not experience any symptoms or any feeling different for minutes to hours later, and commonly resolve within days, but may be prolonged in some situations. This next bullet point is super important. For a concussion to be diagnosed, no abnormality may be seen on standard structural imaging. So if you have a CT scan and we see something on a CT scan, that is no longer a concussion. If you have an MRI and you see something on MRI, that is no longer a concussion. We'll talk about what that is. It's a traumatic brain injury at that point in time. Not to really split hairs, but there's a difference between concussion and being diagnosed with a traumatic brain injury, even though all concussions are traumatic brain injuries. We'll talk about that in just a minute. But we may be able to see some changes on functional imaging with concussions. And the term concussion may be used in an MTBI where neuroimaging is normal or is not indicated. So if you didn't meet the criteria to have an imaging study done for your brain, you can be diagnosed with an MTBI. However, once again, if we see abnormalities on any type of standard structural imaging like CT scan, MRI, so on and so forth, you no longer had a concussion. You have either a mild traumatic brain injury, a moderate or severe traumatic brain injury. So we're reserving concussion for a brain injury that has no evidence on standard imaging. So it's important to realize that. When neuroimaging is performed, and if a trauma-related intracerebral or intracranial abnormality is found, then the injury would be considered, at least at the very minimum, a mild traumatic brain injury, not a concussion. So here is the diagnostic criteria. So once again, spearheaded by the ACRM, the American College of Rehabilitation Medicine, more specifically Dr. Noah Silverberg and Dr. Grant Iverson, two individuals who I've had the pleasure of meeting multiple times and having conversations with. Super smart individuals and very motivated to be able to help clarify the definition of concussion, the diagnostic criteria, so the proper people are given the diagnosis, and the people that don't deserve that diagnosis are not given the diagnosis. And a challenge in the past was concussion was pretty much reserved for just brain injuries associated with sports. We needed a definition and a diagnostic criteria that integrates all the research from the past quarter century, can use across the lifespan from infants all the way to geriatrics, is appropriate in sports, civilian trauma, and more specifically and importantly, military settings, because a great deal of traumatic brain injuries are sustained in the military, but also improves the quality and consistency of mild traumatic brain research as well as clinical research. So here are the criteria for diagnosing a traumatic brain injury. Now, traumatic brain injury is underlined, italicized, bold, because the way the new American College of Rehabilitation Medicine's diagnostic criteria is working is it's basically backing our way into the diagnosis of a concussion. We start off diagnosing a traumatic brain injury, then we determine if we can call it a mild traumatic brain injury, and then we determine if we can call it a concussion. So this will allow for a very comprehensive and less people being excluded from the diagnosis that need to be included. Or to say it differently, less false negatives. Okay, so criteria number one is we have to make sure that we have a mechanism of injury that is plausible. So somebody getting struck in the head with a paper ball does not meet the threshold of a biomechanically plausible mechanism to cause a traumatic brain injury. If somebody gets hit in the head with a brick, different story, right? So we need to have a biomechanically plausible mechanism of injury. The second criterion, we'll talk about how these interact with each other in just a few minutes, is clinical signs. Now, signs are things that can be measured and are objective. So if somebody says, I hit my head and I felt dazed and confused, those are symptoms. However, if somebody didn't know what the date was, where they were located, what time it was, what they were doing a little while ago, those are signs of confusion, which are different than symptoms of being dazed and confused. So we need to have one or more clinical signs. Criterion number 3 says we need to have 2 or more acute symptoms. We'll talk about what acute means in just a moment as well too. Criterion 4, there needs to be some associated clinical or laboratory findings, 1 or more of those. Criterion 5, we're going to look at neuroimaging if it's required. And probably the second most important criterion is criterion 6, which say that numbers 2, 3, and 4, or say differently, signs, symptoms, and laboratory findings cannot be explained better by something else. Drug use, alcohol intoxication, a previously established diagnosis, such as anxiety, depression, ADHD, dyslexia, migraines. So we need to rule out that anything that may existed before the biomechanically plausible mechanism did not cause the signs, symptoms, or laboratory findings that we're seeing right now. Very, very important. Criterion 1 and criterion 6. Super important to make sure we give an accurate diagnosis, not overdiagnose concussion or not diagnose somebody with a concussion that didn't have one. That's why this definition and diagnostic criteria is so important to understand. When can we apply a mild qualifier to TBI? Remember, we just defined what TBI was. Now we need to know when can we apply the qualifier of mild. So instead of saying when can we apply it, let's talk about when we cannot apply it. So if somebody has a loss of consciousness greater than 30 minutes, so 30 minutes and 1 second is a loss of consciousness, can no longer be called a mild traumatic brain injury. Maybe a moderate and maybe a severe traumatic brain injury. So important to realize anything more than 30 minutes with loss of consciousness is no longer considered a mild traumatic brain injury. After 30 minutes, the Glasgow Coma Scale score of less than 13 can no longer be established as a mild traumatic brain injury. In that situation, it'll be moderate or severe. Also, if somebody has post-traumatic amnesia for greater than 24 hours, typically that is prior to the incident, or we call this retrograde amnesia. Anterograde amnesia is sometimes common, but not as common in these situations. So basically somebody sometimes doesn't remember, anterograde amnesia more common than retrograde amnesia. A lot of times people don't remember anything for a period of time after their head injury, but they were able to remember things before. But if any case, if it's greater than 24 hours, it's no longer mild traumatic brain injury. In that situation, it is moderate or severe. So really important to realize that the ACRM criterion give us whether somebody had a traumatic brain injury. Once we get to the end of that, we look back and say, was there a loss of consciousness greater than 30 minutes? Was the Glasgow Coma Scale less than 13? And did they have traumatic amnesia greater than 24 hours? If any of those criteria are met, we can no longer call it a mild traumatic brain injury. So here is your grading scales at 30 minutes. So a Glasgow Coma Scale less than 13, whether it's 12, 11, 10, 9, 8, 7, 6, 5, 4, 3. Those are no longer mild traumatic brain injuries. 3 on the Glasgow Coma Scale is the lowest you can get. It's essentially a complete loss of consciousness. So these are the criteria that we need to be familiar with. Now, also in this new definition and diagnostic criteria, we're introducing a new term. And this new term is called suspected mild traumatic brain injury. So we can have a traumatic brain injury that's mild, moderate, or severe. We can have a concussion. However, there's also this gray, ambiguous area called suspected mild traumatic brain injury. So a suspected MTBI is when the biomechanically plausible mechanism is present, or one or more of these 3 criteria are not met. So if somebody doesn't have 2 acute symptoms, if they do not have 2 clinical findings, or if it's unclear whether the findings can be better explained by pre-existing condition, then we call it a suspected mild traumatic brain injury. But the important thing there is they have to have a biomechanically plausible mechanism of injury. Once again, going back to my previous example, if somebody crinkles up a piece of paper and throws at somebody in a classroom and hits them in the head, that is not biomechanically plausible to cause a concussion or a mild traumatic brain injury. So therefore, we don't know. Now, if that was a baseball, well, in that situation, maybe the force at which the ball was thrown is not able to be calculated. They have some signs, they have some symptoms, but they don't meet any of the criteria. In that situation, what we'd say is that individual had a suspected mild traumatic brain injury. So hopefully that's clear. This is a new term that will be introduced most likely in the June concussion and sport groups consensus, as well as the ACRM's definition and diagnostic criteria of traumatic brain injury. So what does it actually mean to have a biomechanically plausible mechanism of head injury, or brain injury, I should say, to be more specific? Well, essentially what we're looking at is the threshold of individuals to have a concussion is not really able to be determined. It's very gray because there's a large standard deviation when we look at the mean forces, whether they be linear or rotational forces that are needed in order to sustain a traumatic brain injury, more specifically a mild traumatic brain injury and concussion. So what we think for individuals who are adults, 25% of individuals, if we start looking at, for example, quartiles, the lowest quartile of translational forces is about 65 Gs of force. But we have a standard deviation of 30, so many people could be significantly below that. Many people could be significantly above that. And then the rotational head accelerations, we're looking at radians per second. It's about 2,600 radians per second. That doesn't really mean anything to anybody, but it's a lot of rotational force. We know from research that rotational forces cause more injuries than translational forces with concussion. But what we cannot figure out is the threshold for oblique impacts. Oblique impacts have a combination between rotation and translation, and the coupling of those vectors create significantly more force than one of those vectors in isolation. So we cannot come up with a translational and rotational force associated with the concussion or mild traumatic brain injury. And let's face it, every single brain injury and head injury have rotational and linear forces together. So it's very difficult to calculate a minimum threshold of concussion. But what we do know is we know there are some forces in which people do not have concussions. So let's talk about the uncertain forces that are exhibited in a day in and day out basis. Well, hopefully not day in and day out, but more commonly. And then we'll talk about the certainty around no traumatic brain injury. So it's uncertain if whether hitting your head on an earth-fixed object at about 7 kilometers per hour translates to about 5 miles per hour-ish. if that would cause a concussion, because it's about 56 Gs plus or minus 19. So that's in that gray area. That's a lot of force, but still maybe not enough to cause a concussion or traumatic brain injury. Boxing punch. You may have seen people get punched in a ring and say, how did that guy not get concussed? The average Olympic boxer has about 58 Gs of force behind their punch, plus or minus 13 Gs of linear force, and that may or may not cause a concussion. One of the things that's important to realize is that when two objects strike each other, when one has give, there's significantly less translational forces or forces translated from the striking object to the object being struck than if you're hitting your head on something solid. So when somebody gets punched, for example, there's this give in their head. It does create more translational forces. It does create more rotational forces, but over a longer period of time, so the acceleration and deceleration forces are not quite as much as if it was an instantaneous impact and deceleration. So it's kind of contradictory to think that if somebody gets hit and their head moves a whole bunch, that they might be less prone to a concussion, but that's what it seems to be true. Versus if somebody gets hit with the same amount of force and they stop it really quickly, you might have more acceleration, deceleration forces, generating more kinetic forces and therefore more brain injury. So here's what we see in the research as called no traumatic brain injury, meaning including no mild traumatic brain injury, no concussion. A catcher being hit by a 60 to 80 mile per hour baseball in the mask will generate about approximately 30 Gs of force, but not induce a concussion. The average acceleration during a football collision is approximately 20 G forces. Of course, plus or minus 20, so you see some give in both directions, but the average collision in football does not meet the criteria of causing a concussion as far as biomechanically forces. Now, subconcussive impacts are associated with mean velocity of accelerations of 25 Gs, and that's pretty consistent through youth, high school, and collegiate levels, and there's your reference for that behind my mug, but maybe you can't see it. So we know what subconcussive forces are around 25 Gs, and we know concussive forces happen around 65 Gs. So everything in between there is kind of a gray area. And we also see that activities with daily living were studied 49 different ADLs, and people's head movements were measured. And in a day in and day out routine movement of our body, we never exceed about 14 Gs of force. So just driving over a speed bump or stepping off of a curb or missing a step on a flight of stairs is not enough force to cause a concussion, which is empowering for some patients that are afraid to navigate the world because they're afraid they're going to do something on a day in and day out basis and have a concussion. Well, we know that's not true. You have to have a pretty substantial impact in order to sustain a concussion in most cases. Now, do people have lower thresholds of concussion? Sure. Is that the common person? No. And I've had patients tell me that they had concussions from roller coasters. Here's direct out of a research paper. Even the worst case scenario, a roller coaster will not reach the threshold of causing a concussion. Okay. And when we start looking at kids playing in a playground, you think, well, man, kids playing in a playground can get pretty rough. There was a study that was done looking at children in a playground. The maximum rotational forces were 1,700 radians per second squared. The maximum G forces were 25. Once again, maybe reaching subconcussive thresholds, but not reaching concussive thresholds. So let's go through signs of concussion. So remember, signs are things that are measured, and we need to have at least one or more of these signs in order to diagnose a mild traumatic brain injury or a traumatic brain injury or a concussion. So these are things that need to be either observed by you as a physician or others, elicited by you or reported by others, or observable, meaning that if you were in that situation, would you have been able to measure this? So for example, if somebody said that, after my concussion, I was sending these incoherent text messages, now that I look back on it, made absolutely no sense. You ask yourself, well, if I was there at that time talking to that person, asking them about their awareness and their ability to speak and things of that nature, would you have been able to observe a sign in that situation? The answer is yes. So what are these signs of a traumatic brain injury? Loss of consciousness. These are, by the way, not all inclusive, so you can have more than these. Loss of consciousness, loss of motor function or gross motor instability. So for example, walking unsteady, what we call ataxia, Posturing, many people saw an ESPN recently, a football player that developed like these hand posturing with his hands. Posturing is a sign of concussion. Slurring of speech, vomiting, blank stares, changes in personality, more often agitation is what we see. Disorientation, changes in your Glasgow Coma scale less than 15, confusion, amnesia, abnormal eye movements, abnormal pupillary exams, weakness, altered states of consciousness. There are many different signs of concussion, but we need to have one or more of these signs to be able to diagnose a concussion. Now, if we don't have one or more of these signs, we can also go a secondary pathway, which will be better exhibited when I show you the diagram, the flow chart in a minute. If we don't have one or more signs of concussion, we can also have symptoms. So for example, if somebody has no signs at the time of injury, but within 72 hours, they start having symptoms, headache, dizziness, nausea, neck pain, so on and so forth. When we start to see those things, we start wondering, does this person have a brain injury? So if we have 2 or more acute symptoms within 72 hours of onset, and in the presence of a biomechanically plausible mechanism of injury, but we don't have a clinical sign, we need to have 2 symptoms and 1 laboratory finding required. So here are the different symptoms you can have. You guys can look through those real quickly, and those of you watching this later, you can pause it and read them, but we're not going to go through them right now. There are approximately 22 to 26 different symptoms that are generally assessed within 72 hours of having an impact, a biomechanically plausible impact to your head to see if you had a concussion. Here are the laboratory findings. This is a non-exhaustive list: abnormal autonomic testing, abnormal oculomotor function or symptom provocation, balance coordination impairment, vestibular testing that's abnormal or symptom provocation with vestibular testing, cognitive impairment, exercise intolerance, and this is a very interesting category that's coming up real quickly, biomarkers indicative of intracranial injury. We already know that there's one company out there that already has an FDA-approved indicator, a salivary or serum indicator that allows us to determine if somebody might have an intracranial bleed. Once again, if somebody has an intracranial bleed, then they have a mild traumatic, or actually not a mild, either a mild traumatic brain injury or more, but they would certainly have had a concussion as well too. So we can use those laboratory findings as well. So here is a very complicated flow chart as far as what a doctor needs to go through in order to diagnose a concussion. So at the top of the screen, what we see is the most important criterion. Criterion number 1 is a biomechanically plausible mechanism of traumatic brain injury. If somebody has a biomechanically plausible mechanism of traumatic brain injury, then we start to look at what type of clinical signs do they have. Okay. And when we start looking at these clinical signs, what we're looking for are things like observed loss of consciousness, so on and so forth. When looking at signs, there's 2 directions you can go there. You can say these signs are so serious, it warrants imaging. And what we do for imaging is we use something called the Canadian CT head rule. And if somebody meets the threshold of getting a CT scan based upon the Canadian CT head rule, they'll also be reach the threshold of being diagnosed with a traumatic brain injury. So going down that left pathway, if they have a CT scan and the CT comes back positive, meaning we see something on CT scan, they are now diagnosed with a traumatic brain injury. And then we ask ourselves, following along with the green arrow to the right, is the criteria enough to diagnose it as a mild traumatic brain injury, or do we not meet those criteria? And remember, the criteria for mild traumatic brain injury are loss of consciousness less than 30 minutes, amnesia less than 24 hours, a Glasgow Coma scale greater than 13 at 30 minutes are the criteria for diagnosing a mild traumatic brain injury. And in that situation, if we had positive imaging, we could not meet the threshold of concussion. So that individual would be diagnosed with a mild traumatic brain injury. If we do not have anything on imaging, we would then at that point say they at least have a mild traumatic brain injury. Can we diagnose them with a concussion based upon that? And we would say, yes, we could, because they have nothing on imaging. Now, let's just say, go back up to criteria number 1, they have a biomechanically plausible mechanism. we look at criterion 2 and they don't have any signs. As you see right below that red arrow next to criterion number 2, you can have signs and or symptoms and findings. Okay, so criterion number 3, if we don't meet criterion number 2, meaning there are no signs, we would say, do they have 2 or more acute symptoms? And if we say yes, then we say, do they also have 1 or more laboratory finding? If yes, then we go on to criterion number 6 and we say, is there something else that can better describe this situation other than a concussion or mild traumatic brain injury? And if the answer to that is no, then we can move forward and diagnose them with a concussion or mild traumatic brain injury. Okay? And if there's no imaging or imaging was not warranted, in that situation, we would say concussion, not mild traumatic brain injury. So we want to give somebody the least severe diagnosis possible. If TBI is the lowest possible diagnosis we can give, that's what we give. If mild traumatic brain injury is the lowest that we can give because there is something on imaging, we give the diagnosis of mild traumatic brain injury. And if there is nothing on imaging or imaging wasn't warranted, then we can say that individual had a concussion. You can see how important this diagnostic criteria and how well developed it really is. So that covers the diagnostic criteria for traumatic brain injury, mild traumatic brain injury, and concussion. Now, this last diagnosis of suspected mild traumatic brain injury, as you might be able to read on the side, says if they have a biomechanically plausible mechanism, they do not have one sign, they might have multiple symptoms, but they don't have any laboratory finding, then they would have suspected mild traumatic brain injury. If they have a biomechanically plausible mechanism, they do not have any signs, they do not have symptoms, but they have criterion number 4, which are laboratory findings that suggest that they did have a brain injury, then we would say suspected mild traumatic brain injury. Or if they did meet the criteria of having a mild traumatic brain injury, but it's complicated by migraines or something else, and we're uncertain whether the migraines are causing this presentation or it's the mild traumatic brain injury. In that situation, we would diagnose them with a suspected mild traumatic brain injury. So hopefully this helps clarify for everybody the diagnostic criteria that's coming up in June for mild traumatic brain injury, and concussion, as well as the definition that the Concussion in Sports Group is looking to announce as well too. And hopefully this serves my colleagues that are in the professions of caring or diagnosing traumatic brain injury, as well as those that maybe think that they should have been diagnosed with a concussion and they actually weren't appropriately, or maybe inappropriately. Hopefully that this all comes together and is informative for everybody. If you are a clinician, if you are a doctor, a healthcare provider, and you're interested in learning more about this segment was actually extracted from the Carrick Institute's Concussion Bootcamp. So we talk about this a lot more in depth in 2 different programs at the Carrick Institute. One is the Carrick Institute's Concussion Bootcamp. The other one is the Functional Neurology Management of Concussion, where we kind of go in depth on each one of these things. So I only had 30 minutes here to discuss this with you or to share this with you. However, definitely want you to be able to get as much information as you desire from this type of information. So if you are interested in learning more about how to manage concussion, how to diagnose concussion, by all means, let's go ahead and get you signed up for one of the Carrick Institute's courses so that you can learn more about it. So once again, my name is Dr. Matt Antonucci. I am a professor at the Carrick Institute, professor of functional neurology at the Carrick Institute, and I hope that this was helpful for you. So if we have any questions, I can take them. You guys can just either make some comments. And Dr. Schaefer, thanks so much for joining us. Appreciate you as always. And if not, then you can always post comments on here, and I'm happy to answer those in time. So thanks so much, everybody. Hope you have a fantastic day. Bye-bye.